Thank you, Dr. Asim, for the invitation. Am I audible to everybody? And is my screen visible to everybody?
Yes, sir.
Okay, thank you, Gitika. So as discussed that I'm going to talk about the screening and pre-operative biomarkers in prostate cancer. We all know that the important biomarker what we use in the clinical setting is the PSA, prostate specific antigen, which is a serum-based biomarker. But if you see certain data that the PSA count, when it is more than 4 nanogram per ml, the specificity is 94%, but the sensitivity is only 20%. So this is not a appropriate or a perfect biomarker for the detection of the prostate cancer. If you encounter a scenario when you have PSA of less than 1 nanogram per ml, most of us will say that the patient is not having prostate cancer at all. But practically, the false negativity is there, and up to 10% of the patient may have underlying prostate cancer, and they are prone to develop a disease, and the presentation would be quite late if we pick them up. Also, PSA can be seen both in the prostate cancer as well as adenoma. So it is very difficult for us to truly pinpoint whether we are dealing with the malignant disease or the benign disease. Now we have the derivatives of PSA, what we call as the PSA density or PSA velocity to predict the probability of prostate cancer. But again, as I mentioned, that it comes with a lot of limitation of low sensitivity. PSA as a screening method has been tried and has failed and has led to overdiagnosis and consequently to overtreatment, and which is not the right approach. So, but we have now a newer test available, which I'm going to discuss today, both you can say at the serum level, urine level, as well as at the tissue level to predict the probabilities. So now the important test which I'm going to share is the Prostate Health Index, which is called Phi Test, have been approved by US FDA in 2012, which includes or measures three things. One is the total PSA, the free PSA, and the precursor, or what we call as a pro-PSA. Based on this formula, which you can see here, a Phi result is calculated, which is nothing but the prostate cancer probability. If the probability cutoff, if we choose 25, then we can avoid 40% of the unnecessary biopsies. And especially, this is important if you encounter a scenario where the patient have PSA count between 2 to 10 nanogram per ml. So practically speaking, if you are able to prevent 40% of the biopsies in this range of 2 to 10, I think it's a good job done, especially when the DRE is not showing any significant clinical observations. Even the NCCN guidelines recommend the use of Phi test for early detection of prostate cancer, but it does not recommend to use it at the first line. So practically we have to use PSA, and if you suspect, then you should go for the Phi index, that is a prostate health index. And then you can see whether you want to go ahead with the biopsy or not. Similarly, another serum-based biomarker called K-score. This is K stands for Kelly-Karen, and we have 4 Kelly-Karens to estimate in the serum. That is a total PSA, free PSA, intact PSA, and human Kelly-Karen 2, HK2. And we should all know that the PSA is also called human Kelly-Karen 3. Additionally, this algorithm takes into account the patient's age, the DRE results, and the prostate biopsy history, and then come up with a score. If the score cutoff is, let's say, 9%, then the patient can be avoided up to 43% times for the biopsies. So again, this is very, very important. Both the Phi results and the 4K score performs better as compared to using the PSA or the free and total PSA in men between the range of 2 to 10 nanogram when you encounter the clinical scenarios when you have the PSA between 2 to 10 actually. So having said that, these are two important take home for now. We'll now go to a urine based biomarker. Again, when you do the prostatic massage, after 3 strokes of prostatic massage, it has been shown that the specific gene called prostate cancer gene, long coding RNA, is secreted in the urine. And this is seen especially in the prostate cancer as compared to the benign prostate hyperplasia, which is almost 80 times higher. And this test called ProGensa, which detects this long non-coding RNA of PCA3, was approved by FDA in 2012. So ProGensa is practically looking at the messenger RNA of PCA3 as compared to the PSA mRNA. So again, we should be familiar with the 2 important genes to be talked about. One is PSA and the other is the PCA. So PCA is more sensitive and specific to pick up the prostate cancer. So let us see the scenarios. When the PCA3 results shows less than 20, then there is a very low probability that the patient is having cancer. If the results are in the range of 20 to 35, the recommendation says to retest the sample or urine test after 6 months. And if it is more than 35, then there's a higher risk of prostate cancer and it justifies prostate biopsy. So practically speaking, the indication of ProGensa PCA3 test is whether it is necessary to repeat the biopsy after the initial biopsy is negative. So very, very important test and clinical scenario when we encounter when the biopsy is negative, this test is very, very helpful. Again, we have some tests which can predict the use of or you can avoid biopsies like Select MDX or Tempress TMPRSS2 ERG fusion. So Select MDX is basically detecting the presence of HOX-C6 and DLX1 mRNA in the urine. And it is just to assess whether the patient have a higher probability of prostate cancer or not. If the probability is higher, then prostate biopsy is recommended. If it is low, then you can prevent unnecessary biopsies in up to 53% of the cases as reported in the literature. Similarly, Tempress ERG fusion is considered to be one of the early events in prostate tumorigenesis. It is usually seen in 50% of the prostate cancer. And detection of this is again quite specific for a higher risk of prostate cancer, but the sensitivity is not that great because it is seen in up to 50% of cases. So standalone sensitivity of this test is not that good, but can be combined with other parameters to predict the probability of prostate cancer. Similarly, we have Michigan Prostate Score called MIPS or ExoDX Prostate IntelliScore, again both based on the urine. It was the MIPS or Michigan Prostate Score was developed in 2013, which included the above discussed biomarkers like serum PSA, the urinary PCA3 mRNA, and urinary Tempress ERG fusion. So when you combine these 3 biomarkers, so you come up with a score which is quite, you can say, robust enough to predict the probability of prostate cancer and can avoid in up to 47% times unnecessary biopsies. So again, very useful. Again, we have this ExoDX, which is based on the exosomal detection of the RNA of important 3 genes, which is mentioned over here, which includes SPDEF, ERG, and PCA3. And this can avoid up to 27% of the unnecessary biopsies if done alone. Now we have some other biomarkers. Once you do, let's say, a biopsy. So the first biomarker which we have discussed is that when the PSA is high, should we do a biopsy or not? It was to avoid unnecessary biopsies. Now, let us say the biopsy is done, but the biopsy came out to be negative. What is the probability the patient still has prostate cancer? So this is called confirm MDX, which is based on the epigenetic changes, which is usually seen in the normal cells, very close to the tumor cells, and the methylation pattern of 3 promoter region of 3 important genes, APC, RAS, SSF1, or GSTP1, which is involved in various aspects of tumorigenesis if you see methylation of these things, you can predict that the patients still have high-grade or high-grade prostate carcinoma. So a repeat biopsy can be recommended in these cases to confirm, but this is quite robust enough to tell that yes, there's an impending cancerous or tumorigenesis which has not yet been picked up on the biopsy as of now. But the chances that if you do a prostate surgery, you may end up having small foci of prostate cancer somewhere in the specimen. So again, a call confirm MDX, but not yet approved by US FDA. Now you have the biopsy done, and the Gleason score is 3+3 or 3+4, that is low or intermediate. Now the big question comes that what are the chances of recurrence? So this test Oncotype DX, like similar to the Oncotype DX in breast, we have Oncotype DX in prostate, which determine the expression of 12 carcinogenic genes and the 5 reference genes, and then they come up with a score between 0 to 100, and higher the score, chances that the recurrence will be high, and it helps to risk stratify the patients, especially in a newly diagnosed case, for the probability of recurrence. And this is basically a prognostic assay, so we cannot say that really can we be aggressive in those scenarios or not, but yes, certainly we can tell that the outcome would be not good, especially in the low risk. Hello. And now, similar to the Oncotype DX, we have a ProMark assay. The Pro stands for protein based. It is a 8 protein signature based assay, which talks about the expression of these proteins, and a score between 0 to 1 is given, especially in scenarios of low and intermediate risk cancers. And again, the idea is to identify the subset of low and high risk patient who needs more aggressive treatment. Again, a prognostic assay. Similarly, we have a Decipher assay, which is based on the RNA expression of 22 different genes, and which can predict the likelihood of clinical metastasis within 5 years after radical prostatectomy, and 10 years mortality specific for prostate cancer in men with high risk pathology or high risk clinical features. So again, very, very important. This can also be used to determine the time of post-operative radiotherapy, whether we should go for early adjuvant therapy versus salvage radiation therapy at later time point. So again, we have another test called ProLaris, again a prognostic assay, which is basically based on the RNA expression of 31 important genes as compared to the 15 housekeeping genes, and gives a ProLaris score. And this ProLaris score is a strong predictor of oncologic outcomes and adds information that is new and independent of the standard clinical pathological features, which is especially the PS and Gleason score, what we normally use in the clinical setting. And it can guide us for active surveillance versus definitive treatment, and quite a robust test. And it is available in India, but it goes to the US, but it is available in India. So besides this, when we do not have many access to the biomarkers, we have some calculators. There are almost like 127 risk stratification tools available, which have been studied in randomized, you can say, in various studies. Among them, 6 have been well studied. And I have mentioned 3 of them, which you can refer to: the Prostate Cancer Prevention Trial Model, the Stockholm Model 3, Rotterdam Prostate Cancer Risk Calculator. So all these 3 important calculators uses the clinical parameters as well as the serum-based biomarkers to identify the risk. There are some new risk prediction models which are being developed, which uses the new emerging biomarkers, as we have discussed, the 4K score, the select MDX, PCA3 or Phi Test, along with the standard clinical data to predict the possibility of the prostate cancer, as well as the possibility of early recurrence. And especially all these calculators can help the patient in terms by reducing the biopsy rate up to 55% with the false negativity of 2%, where they can miss the castration sensitive prostate cancer. So this is an algorithm which I wanted to share. Let's say, for example, that you suspect a patient of prostate cancer on a PSA or a DRE or TRUS or MRI. Now the question is, should we go for biopsy or not? You have plethora of tests, that is the PSA derivatives, the PHI, the 4K score, ExoDx IntelliScore or select MDX. If the biopsy is done and the biopsy comes out to be negative, then you have the option to use Progensa, Tempress, ExoDx IntelliScore, select MDX or confirm MDX. Should we repeat the biopsy or not? This will tell you that there are still chances that the patient may have prostate cancer. And if the biopsy comes out to be positive, and you are going to risk stratify the patient, not only based on the Gleason score, but also on the genomic marker, we have to use ProMark, Oncotype DX, Polaris, and the Decipher test. Once the risk stratification is done, and now you end up having high risk patient, definite treatment is given to those patients. And on follow-up also, Polaris.
My apologies, sir. You are left with just 1 minute to conclude your presentation.
Last slide. So on the follow-up, you can use Polaris and Decipher to predict the recurrences. Even for the NCCN guidelines, even for the regional cancers, not for the metastatic one, the non-metastatic one, the germline testing is recommended, especially for the high and very high risk group, and for the patient who have family history or intraductal or cribriform histology. So this is something which I wanted to emphasize, and this is going to be very helpful in terms of predicting the right treatment options for the patient. With that, I thank you all for the kind attention, and I hope I have completed in time actually.
Yeah, so thank you, Dr. Amit Verma. So your talk was very enlightening, and especially how to avoid the unnecessary biopsies. And thank you very much for your enlightening talk.